Okay, so the first patient is a 78-year-old male, and who has been diagnosed with upper tract renal cell carcinoma and urothelial carcinoma in the left renal calyx. So he had a prior biopsy confirmed that it's a high-grade papillary urothelial carcinoma, and this is his follow-up for the urine specimen. So we've seen similar specimen last week that we discussed about the presentation in the urine cytology specimen of the upper tract urothelial carcinoma. Sometimes, most of the time, the lesional cell might be quite scant. So in this situation, usually we won't be able to make definite call at the beginning, but this is the cells that we want to look for. Okay, so in the center of this high power field, we do see these are benign intermediate cells, and then we move to these cells. So it is a single cells, and we do see very high NC ratio because we can see that this is nuclear membrane and this is the cell membrane, so the NC ratio is very, very high. The chromatin pattern suggests that it is highly degenerated, so it is kind of like smashed, a little bit irregular. However, the nuclear membrane is still intact without a lot of beating, so it's still relatively preserved, and this is suspicious for high-grade urothelial carcinoma when you see something like this. So this is the cell that we want to look for. On low power field, it might be very indistinct because it mimic like inflammatory cells. And when you go to higher power, you can tell that the size of the nucleus is different from a lymphocyte, much bigger. So this is the cell that we want to look for. So based on the cytomorphology, I think we are this cell is highly suspicious for high-grade urothelial carcinoma. The only problem is it is highly degenerated, as well as the number of the cell is very scant. So in this situation, usually we will use the suspicious for high-grade urothelial carcinoma category. Okay, so this is the cell that we want to look for when we do urine cytology screening. So the most common scenario would be the upper tract urothelial carcinoma. So basically we have like around 5 cells looks like this. The other situation is that if you have a bladder tumor, but it is carcinoma in situ instead of papillary urothelial carcinoma, it can also present as these very scant but high-grade looking cells. Okay, so this case that we also are going to call suspicious for high-grade urothelial carcinoma, and this is the cell that we want our screener to look for when we do the screening for the urine cytology. The second case is also coming from urine, and this is not very common, but the case is very classic. So this is coming from a 50-year-old male, and this is a washing urine cytology specimen coming from the right renal pelvis. So because it is a washing cytology, we expect to see a lot of cells in the specimen. So the cellularity is okay, so it is adequate for our examination. So on low power field, we do see cluster of cells as well as individual cells in the background. So here is a very big fragment of where's my arrow? Yeah, it's here. So this is a very big very three-dimensional fragment of cells. So it actually looks like a papilla. So it looks like a detached papilla because it had fibrovascular core in the middle. So then we go to the middle power. So here in the background, we can appreciate that we have a lot of relatively bland looking, but the NC ratio is slightly a little bit increased, and a lot of cells have these like a elongation or stellate type of feature. But the nuclear chromatin pattern is lack of hyperchromasia. So the NC ratio is not as high as the cell that we see. It's about 0.7. Here is about between 0.5 to 0.7. Additionally, we do not see striking hyperchromasia. But overall, these cells have a very monotonous appearance. So here we have a benign, intermediate, and umbrella cell. But in the background, we have a lot of these smaller cells with a little bit high NC ratio and a very monotonous appearance. And these cells seems to be detaching from this papillary structure. So this is a very classic cytology example of a low-grade urothelial neoplasm. So when we have a specimen like this, we would be it is highly suggestive that it's a low-grade urothelial neoplasm. And based on the current Perry system, it is not very well characterized, because in the Perry system they recommend that you really need to see like a fragment of papillary structure you can definitely call low-grade urothelial neoplasm. However, based on the Perry system, you still need to use negative or high-grade urothelial carcinoma category and then make a note saying that compatible with low-grade urothelial neoplasm. So it's kind of a little bit complicated. So in our reporting scheme, because we don't strictly follow the Perry system, usually we will call these atypical, and we can make a note saying that compatible with low-grade urothelial carcinoma or suspicious for low-grade urothelial carcinoma. And because the patient also received a biopsy, I think we will just wait for the biopsy for the result. But these cytology specimen is classic for low-grade urothelial neoplasm because we have the papilla. And the background morphological pattern is very classic for a low-grade urothelial neoplasm, which includes pons lump and low-grade urothelial carcinoma, sometimes papilloma as well. But the morphology, cytomorphology is not very distinctive among these different tumors. And to be honest, the pathologic examination is also very subjective. So sometimes we would just use the low-grade urothelial neoplasm as our category. 这个换新了，所以比较快了。Okay, good. So next is also a urine cytology specimen coming from an 83-year-old male. So Dr. Shi also actually see this specimen last week from the same patient, and this is the third specimen from the same patient. So on low power, this is avoided urine. On low power, we don't have a lot of cell because it is avoided urine. And sometimes if the urine specimen has been kept in the clinical site without immediate preparation, it's very common that you can see like a fungus growth in the urine. So this is not coming from the patient. This is coming from the environment. So in our practice, usually we won't report fungal spore in our urine cytology specimen. And here is relatively indistinct, but on low power you can appreciate it is very hyperchromatic. So we have one cluster of very hyperchromatic cells, and when we go to higher power, the cell have a very high NC ratio, and the nucleus is actually the size of the nucleus is actually increased. This is a relatively benign looking, probably histiocyte. So here we have an Indian fire and the molding pattern. The chromatin pattern is also appear to be salt and pepper. So this is a small cell carcinoma. So the patient is actually have a small cell carcinoma, I think in the prostate, and also metastasized to the liver. A little bit unsure where is the primary because primary prostate small cell carcinoma, the patient usually need to be treated with like a hormone therapy to develop a small cell carcinoma. And because the patient already have multiple disease with distant metastasis, so it's a little bit uncertain if it is actually coming from the prostate, or it could be a lung primary small cell with multiple metastases, including the prostate. But because the patient already confirmed had the TRUST biopsy that prostate is positive for small cell carcinoma, and the prostate is connecting to the urethra, so the tumor cell can shade into the urine. So in urine cytology specimen, we would rarely see small cell carcinoma. It can be either coming from urothelium, so it can be a primary bladder small cell carcinoma, which usually doesn't require prior treatment to develop small cell carcinoma, or this is much rare, but coming from the prostate, usually the patient need to be treated as prostate cancer, and then to have transdifferentiation similar to the lung cancer scheme. So here we have a very good example of small cell carcinoma in the urine, and because the patient is confirmed to have prostate location to have small cell carcinoma, so this is compatible with the coming from the prostate shedding. The patient has 3 urine. The first one, Dr. Shi called small cell. This one we call small cell. The middle one was called negative. So please take a look. It can be negative, but just we can take a look to confirm if it is negative. So we move to pleura effusion. So we have a lot of lung cancer today as well. And this is coming from a new patient, a 46-year-old female, so very young. And here we have classic, like a cluster of cells arranged in glandular pattern. And the cell have prominent nuclear atypia, so this is consistent with primary lung cancer with pleura effusion involvement. So we will do TTF1 on this cell block, and this cell block is also good for the molecular testing as well. So again, another patient, history of lung cancer, and so the patient has been treated. In this case, the tumor cell start to develop like a poor cohesion, so it's poorly differentiated. So most of the cell seems to be single cell. So in this setting, sometimes it's quite difficult to make a distinction between is it reactive mesothelial cells or these are poorly differentiated carcinoma. So the diagnostic clue for me, I would usually searching for first striking like a very prominent nucleola, which is more common in the metastatic adenocarcinoma. The second, I would try to look for cytoplasmic vacuole, which is also more common in metastatic adenocarcinoma. But if you ask me, what is this cell? Is this a reactive mesothelial cell, or is this a poorly differentiated adenocarcinoma? That would be very difficult because the nucleus is centrally located, and it also seems to have a double contour over the cell membrane. So if you ask me the individual cell, could it be the mesothelial cell reactive? I have no idea. But if you take a look at the overall picture, and if you compare the size of the adjacent lymphocyte, I think maybe most of the cells were metastatic adenocarcinoma. So this is an example of a poorly differentiated adenocarcinoma with pleural effusion involvement. So here is more classy. You have eccentric. So eccentric is less likely to be mesothelial cell and prominent nucleoli, and the size is basically as big as a lymphocyte. So this is a poorly differentiated adenocarcinoma. But what is this? I have no idea. It could be a mesothelial, but it can also be a poorly differentiated adenocarcinoma. And these two might be reactive. I don't know. Yeah, but these two I'm pretty sure it's adenocarcinoma. So in this poorly differentiating scenario, sometimes the so-called two-cell population is basically a spectrum, and it is very difficult to be certain within the spectrum in the middle, is it metastasis or reactive. But what we do is just search for the end of the spectrum, the most high grade, the most diagnostic cell, and then we can make our diagnosis. So again, this is lung pleural effusion metastatic adenocarcinoma, and the different case with very similar presentation. So we have this type of specimen very frequently. So it is basically not a big problem to us. So then we move to the fine needle aspiration. The first specimen is coming from a thyroid. So this is a classic example, right? This is hypercellular. In the background, we don't have a lot of colloid. The cellular arrangement, we do see monolayer sheets of cells, as well as more three-dimensional, like a decapitated papillary structure, which characterized by like a luminal border at the three aspect, but the fourth aspect was like a blunted. So this is like a decapitated papilla. So this is a classic example of papillary thyroid carcinoma, just based on the low power feature. On high power feature, we do see multinucleated giant cells, and we will usually search for nuclear inclusion in the monolayer sheets area. And so here we do see the cell is relatively monotonous and with oval shape, a little bit disorganization, some with grooving. Giant cell here as well. So we can look for pseudo inclusion because it is very classic. So we didn't make a dot, but I think it's there. So let's take a look. Yeah, but even without the nuclear inclusion, if we have the diffuse means like almost every cells had the nuclear atypia suggesting as PTC, we can still make definite call that it is PTC, category 6, definite call for PTC. So I did not see inclusion now, but this is definitely PTC, so we are going to call this PTC. The next specimen is coming from an 83-year-old female. So it's an old lady, and she had an enlarged lymph node in the left subclavicular. So this is the aspiration of left subclavicular lymph node. On low power, we already see hypercellularity, a lot of cells. So clinically, if you have an enlarged left side subclavicle lymph node, it can be coming from multiple locations. It can be coming from the head and neck region for sure, but it can also be coming from the GI tract because it is where the lymphatic goes into the thoracic duct, and the thoracic duct go into the bloodstream through the left subclavicular vein. So this is also the route that we can drain some metastatic lesion from the GI tract. So in this specimen, we do see these are adenocarcinoma because we have classic like glandular arrangement, even a little bit of goblet cell feature. And here we do see nuclear atypia prominent nucleolus. So this is compatible with adenocarcinoma. And because of this location, and she doesn't have any history, this is coming from an ENT outpatient clinic. So she doesn't know anything about like where is the lesion at all. So because we have a lot of cell in our specimen, so we will usually try to navigate for the primary, at least for our clinician to make the clinician can send the patient to the right department. So when we having this specimen as this cellularity, we will usually think that maybe it can be it can have some residual lesion cells in our cell block if we do a cell block, but because our tag already say there's no tissues, I was a little bit hesitate that should we do a cell block or should we just do a direct cytospin for the immunohistochemistry. And for this case, I think maybe we just do a cytospin because I don't want to do a cell block and there's nothing there, and then we miss the chance to help this elder lady. So in this scenario, I use I just ordered three lineage-specific marker. First of all, TTF1, just to try to check because lung cancer is still very common. And the second is CDX2 because I think it's also highly likely that it is coming from the GI tract. And the third one, because she is a lady, she's a female, we just want to confirm could it be also coming from the breast, because sometimes the breast cancer can go through the axillary drainage and to the subclavicle. So we do GATA3, so I ordered 3 different stands for this case, and we will use the cytospin preparation because it's more likely that we will still have cells in the cytospin. So the next specimen is parotid gland aspiration. So in this specimen, just on low power, we have a cystic kind of necrotic background, and then we start to see some keratinized cells. In the background, we have a lot of cells look hyperchromasia. Some looks like necrotic with a spindle morphology. So this is classic for a squamous cell carcinoma. So if we suspect for squamous cell carcinoma, we want to look for like a well-preserved, more parabasal or lower level cells. So I think this is a good example. Here we have maturation, and then here we have the basal part. All the cells look very hyperchromatic with high NC ratio. And in the background, we do see tumor necrosis. So this is diagnostic for squamous cell carcinoma. Parotid is not the location for primary squamous cell carcinoma. So majority of the time, this is coming from metastasis of a primary head and neck squamous cell carcinoma. The patient do have a SCC history, and the origin is in the maxillary sinus. So it's a sinonasal primary squamous cell carcinoma. Nowadays, for the primary sinonasal squamous cell carcinoma, there is still a high possibility that is high-risk HPV associated. So we would usually want to have HPV testing, either P16 or DNA testing. For this case, because she is a guy, he already has been diagnosed, by biopsy, so they have performed it in the biopsy specimen for the primary lesion, which is negative for P16. So this is likely HPV negative squamous cell carcinoma. So we would just call this squamous cell carcinoma and compatible with metastases. So there is rarely a primary squamous cell carcinoma. We have a few interesting squamous lesion. This is coming from a 24-year-old female. This is coming from a post-auricular mass lesion. So in this specimen, we do see some cells, and it seems to be also cystic because we see some like material as well as histiocyte in the background. So when we go to higher power, we do see that this is histiocytes. And we have some sort of atypical cells in a clusters. And some cells actually looks like multinucleated giant cell, such as this one. So this is a multinucleated giant cells. I think this is a bigger multinucleated giant cells, and here are some histiocytes. And this is also a multinucleated giant cell. You see, this is like a rosette type of like a peripheral multinucleation. So this is foreign body type or Teuton type giant cell. So it seems to have a granulomatous inflammation with a cystic change. And then you move to the adjacent material. What is this? So you start to see there are some lamination. So this is actually a degenerated keratin material. Okay? So in this specimen, we see mostly atypical cells, and you need to make determination, and this is giant cell, this is not epithelial cell, because some of them might appear to you as epithelial cell because of the arrangement, but most of them were giant cells, and we have degenerated keratinized material. So the most common scenario for this one would be a ruptured epidermal cyst. So this is compatible with a ruptured epidermal cyst. Squamous cell carcinoma sometimes can also induce prominent granulomatous inflammation if it is well differentiated, highly keratinized. But the clue is that we need to search for the parabasal, atypical parabasal cell. In this case, we do not see any of them. Additionally, this is coming from a 24-year-old female. It is highly unlikely that the patient will have a squamous cell carcinoma. And additionally, the patient is actually had the aspiration at the same site 1 year ago, exactly 1 year ago. And then I called the clinician because last time we already called compatible with ruptured epidermoid cyst. What's happened? So this is keratin material. This is more apparent, right? Because this is not as degenerated as the prior one, but I mean you need to make distinction. If you see only this degenerated material, you need to know that this is actually keratin. Okay? This is easy, but this is not easy. So the clue is to see this lamination arrangement. So the patient say that, the clinician said that because the patient doesn't want surgery, and she feel symptom relief because the epidermal cyst is very big, so it deviate her glasses like this. And every year she want to do the aspiration to release that so she can wear her glasses properly. So that's kind of strange, but anyway, you need to respect the patient's decision. So this is repeated like a very big epidermal cyst, and she keep on aspirate. I'm not so sure if it will becoming a squamous cell carcinoma after like chronic inflammation. Again, a very interesting specimen. So today we have a full spectrum of squamous lesions, squamous aspiration in the head and neck. So this is coming from a 31-year-old female. This is coming from level 2 cystic lesion. So in this lesion, what we see is only a nucleated squamous epithelial cell. So we have squamous cell carcinoma that you see, we have ruptured epidermoid cyst that you see, only the degenerated keratinized plaque. And here we have individual squamous cell, mostly superficial, a little bit intermediate, but all of them were enucleated. So this is also kind of that we will see in the head and neck region. Sometimes we will just see this very bland looking squamous cystic lesion, and we need to do some determination. So based on the clinical impression in the CT report, they say it could be metastasis, but she's only 31-year-old, and it could be coming from a second brachial cleft, like a pouch, to develop a brachial cleft cyst. Usually for the brachial cleft cyst, we will see sometimes more inflammation, and not only the squamous cell, because most of the time you will have respiratory epithelium and some mucinous material, but in this cystic lesion, it is very, very clean, only these clean nucleated squamous cells. So I think for this case, we will call this negative. There was some interesting material. I think this is not a cell. This is, I don't know what it is, like Huafen, or it's very, very weird looking material. But yeah, we don't see a typical squamous cell because there's no cells with nuclear. This cell doesn't look like necrotic. It looks like they are at their end differentiation. So for this case, I just call these negative. We only see a nucleated bland looking squamous cells compatible with maybe it's epidermal cyst not ruptured, but because the location is unlikely, it seems to be more deep-seated, or it can be a brachial cleft cyst, but overall it looks like a benign squamous cyst. Okay, so that's for all the cases today.